Good afternoon, everyone, and thank you so much for joining us today. My sincerest apologies. Thank you so much for your patience while we work through a few technical difficulties. I'm just going to go ahead and jump right in so as not to lose any additional time. So thank you so much for joining us today. This is the California Primary Care Association's with Partnership Health Plan and the National Center of Excellence for Eating Disorders, addressing systemic care coordination between health plans. This is the 4th webinar in our eating disorders series, so hopefully you were able to join the previous 3, but we are looking forward to wrapping up our series today. So before we get started and I turn things over to our presenters, just a couple of housekeeping notes to make our time more successful. You may have noticed that attendee phone lines are muted and they will remain muted throughout the presentation. However, there are 2 ways you can submit questions or comments and engage with our panelists today. The first of which is by clicking the radial button with a small hand icon. When you click that button, this will alert me that you have your hand raised. And when we break for Q&A, I will then open up your individual phone line and let you know when you have full audio connection to present your questions. Additionally, you can use the question box in the webinar toolbox on the right side of your screen. All questions chatted in will be received by me, and I will then present your question on your behalf when we break for Q&A. You can also use the same question box to communicate with me any needs you might have, and I will chat directly back to you. So please continue to monitor that box throughout our session for any communications. So we did send an email with the handouts for today's webinar about an hour before we got started. So hopefully you got those, but if you did not, you can definitely download those in that handout section in that same right-hand webinar toolbox on your screen now. So thank you for registering for today's webinar. Please visit our website at cpca.org to register for future trainings and events. And at this time, what I'd like to do is introduce our panelists. So up to bat first is Dr. Erin Parks. She's the assistant professor with the University of California, San Diego. And joining her are panelists from Partnership Health Plan of California, Laurel McCarthy, Dr. Jeff DeVito, and Margaret Kiss. I apologize for not testing your last name before we got started. So Margaret, I'll let you pronounce your last name when you jump in, but at this time I am going to go ahead and turn things over to Dr. Parks. So Dr. Parks, I am passing presenter control to you now.
All right. Hello, I'm going to share my screen. Let's see here. Everyone can hear me okay, and let me, okay, show this window.
All right, we hear you great. I see your beautiful smile, and we're just waiting for your slides to load.
Okay, looks like they're waiting to load.
There they are.
They're there, good. We've made it, and they're changing. We've done it. Yes. Okay. Technology. So hello everyone, thank you for being on this call. As Tiffany mentioned, my name is Erin Parks. I am a clinical psychologist, also a researcher that has been interested in evidence-based treatments for eating disorders for the past about 10 years. I'm originally a neuroimaging researcher, that might come up a little bit, but got really interested in eating disorders because they are a place where we can take this neuroimaging research and turn it into treatment we're doing right now. I am faculty at UC San Diego. I was one of the co-directors at the Eating Disorder Center there. We offer partial hospitalization and IOP, but I stepped down to an adjunct role at the end of 2019 to do a startup. I'm the Chief Clinical Officer now at Equip Behavioral Health, and those are my disclosures. Equip Behavioral Health provides telehealth treatment for eating disorders. So we work with different counties in California, but also other commercial providers across the United States to help where there's a need. There's a shortage of eating disorder specialists, and we're going to dive right into that and talk about that today. So the grass isn't greener. We would receive a couple thousand calls per year at UC San Diego asking for help and finding providers, and people would call from all around the country. So this is, we have a shortage in every single community. And something that also always stuck with me, we'd often have people who would come from around the world to get treatment at UC San Diego. And some of them would say, like, I'm one of the wealthiest people in the country. Like, people actually say things like that. And it took me 3 really horrible treatment experiences before I found a good one. So the problem of access isn't exclusive to just people who are underinsured or just people in some communities. People in all communities are finding that there's a lack of access to treatment providers that do evidence-based treatment for eating disorders. The shortage of treatment providers has definitely been hurt by the proliferation of these for-profit residential treatment centers. There are some great residential treatment centers that are for-profit, but there are also a lot that are not so great. Right now, about 95% of the treatment centers are owned by the same 5 or 6 private equity firms. And one of the things that we know, and we'll talk about today, is that most of the treatment centers don't work, and we have no evidence actually for any residential treatment center that is effective and working. We know that 50% of people relapse after their first stay, and then after every subsequent stay, that number keeps going up and up. So what are we going to do? We've got a shortage of treatment providers in the outpatient setting, and then if we send people to residential, we know that that doesn't work, and it might actually make treatment worse. And so the answer truly is you becoming an expert in eating disorders. There is no expert to send people to, but you can become an expert in eating disorders. Quickly to review the different levels of care that we're going to talk about. So my understanding is you are all seeing patients in the outpatient level of care, and you'll notice that I made that step at the bottom the largest level of care, because that's where 90% of patients should be treated. In Europe and Canada and Australia and places where we don't have this private equity for-profit residential treatment model, 90% of patients are treated in an outpatient level of care and treated quite effectively. When we talk about stepping people up to higher levels of care, the next level up is IOP. So we're getting into the alphabet soup of acronyms in behavioral health. So IOP is intensive outpatient. People are there between 3 and 5 days a week, typically for about 3 hours. A step up from that is partial hospitalization, PHP, also called day treatment. Stepping up from that is residential. That's where you live someplace 24/7. And then above that is inpatient. That's when you're someplace for 24 hours a day, but it can either be a psychiatric or a medical inpatient unit. So one thing to keep in mind is that consumers and healthcare providers, a lot of these terms aren't in their lexicon, and they get these different terminologies mixed up. So some people ask for inpatient when what they mean is residential, but also a lot of people would call UC San Diego asking, I'm looking for a residential treatment program. But when we talked to them about it, what they really needed and what their symptoms fit was, what they needed was a strong outpatient provider. So why is this happening? Well, the private equity-backed residentials have done a great job of convincing large numbers of people that treatment should be going from the top to the bottom, meaning that when you get sick, you should start at the highest level of care possible, the residential, and then after you're getting better, then you'll slowly titrate and go down. But you'll know that this is not what we do really for any other illness, physical or mental. So if you hurt your arm playing basketball and you went to the doctor, we would not start with amputating the arm, right? We would start with a sling, then maybe a cast if it's broken. Then if that didn't work, then we would go to pins to surgically set it. We would try lots of less invasive, less costly things before you go to the highest intervention possible. And one of the things that the research is starting to show is that we might be doing a lot more harm than good by starting from the top and sending people down. So most eating disorders are going to start in adolescence around the time of puberty. And I can no longer see how, 66 of us are on the call. I can't see you all raising your hands, but if I asked how many of you would not go back to middle school, I think at least half of you would raise your hands. I know I would not go back to middle school. So you're in middle school, you start developing symptoms of an eating disorder, you talk to your well-meaning school counselor, pediatrician, uncle and aunt and parent, and they all have kind of heard the same thing. You have an eating disorder, you go to residential. You go to residential, and I talk with a lot of people who are in recovery, and they say, I loved treatment. Treatment was safe. I didn't have to deal with my triggers. I got to be around other people who understood me. Sometimes I got to ride horses or stare at the ocean or lay out by a pool. The hard stuff was getting better in real life. And so then when you leave this bubble, this not real life of residential, and you go back to middle school, and all that middle school has to offer, when things get hard again, you want to go back to residential, and you start identifying more as a patient than identifying with a middle schooler who's running for student government or auditioning for the play. So one of the things that we're trying to really educate consumers on, and all healthcare providers, is the idea that treatment really should be starting at the bottom, at the outpatient level of care, and only in the worst case scenarios starting to use higher levels of care. People can and should get better at outpatient care, and that's what we see when evidence-based treatments are used. So summarizing the soapbox, there's no evidence that residential treatment centers work. There's still zero published evidence that it works. There is evidence that residentials might make it worse. And then lastly, you can't build a life worth living if you're not living life. When people are depressed, they want to stop being depressed. When people are anxious, they want to stop being anxious. But when people have eating disorders, there is an understandable ambivalence about recovery. There's a part of them that wants to get better. I like to talk about it's the part that wants to reclaim their brain. They're sick of their brain being monopolized by thoughts of food in their body. But there's a part of them wants to hold on to their eating disorder because it serves a purpose. It helps them when they are experiencing extreme emotions. It has a role to play. And if you want someone to stop identifying with their eating disorder, we need to instead give them something else to identify with. That being someone in a middle schooler in student government, being in a play, being a basketball player. And so in order to start doing that, you need to be living a life so you can build this life worth living. One of the things that's challenging, not just for our patients and their families, but for all of us as care providers, is that treatment that feels good often doesn't work, and treatment that works often does not feel good. So right now, there's a lot of outstanding treatment providers who care very deeply about their clients, who slip into eclectic treatment, treatment that feels good. And I think most of us who go into this profession, we can talk to someone for an hour and we can make them feel good. We can be active listeners, we can validate what they're feeling, and they can leave the session being like, that felt good. I can also leave a massage and say that felt really good, and I can leave a happy hour with friends and think that feels good too. But none of those things are actually healing an eating disorder. And when we look at treatment that works for eating disorder, specifically when we involve the family and do family-based treatment and use food as medicine, we know that treatment works, but it doesn't feel good. It doesn't feel good for the patient to eat in order to recover. It doesn't feel good for the parents to do things like say, you're not going to have your phone until the next meal that you complete, and to be upholding consequences day in and day out. Because eating is not something you just do once a week, right? You got to do it 5 to 6 times a day to recover. That doesn't feel good for the parents. But also, it doesn't always feel good for the providers. I mean, sometimes we have to have some really, not sometimes, always, with every case, have some really difficult conversations with the family members. So for instance, I'm treating a child who's hypermetabolic, and so in order to gain 1 pound a week, they have to eat at least 3,500 calories a day. It's hard to eat 3,500 calories a day every single day, and it's really hard if you emotionally and physically don't want to eat. And one of the parents were trying really hard, but when I was looking at the foods that they were serving their child, or while they were describing them to me, I'm like, listen, like, I know that you want to use only, you want to minimize the gluten in your household and minimize the sugar in your household and minimize the dairy in your household. But it's really hard to do that and still feed them 3,500 calories a day. We need the carbs in order to do that. We need the cheese in order to do that. And talking with the parents about some really difficult decisions about, it makes sense that you don't want to eat gluten because you believe that it causes inflammation in your joints. But the issue your child is having right now isn't joint inflammation. The issue is that they need extra nourishment. Those calories are what they need right now. So treatment that works often doesn't feel good. So one of the biggest things we can all do as we're becoming eating disorder experts and treating eating disorders is building our own distress tolerance. So I keep doing this. I keep talking about things that are on the next slide. So treatment doesn't feel good for the patient, the parent, the family, the therapist, and the care team. So how to treat eating disorders. The most important piece is creating and uniting a care team. We need everybody to be on the same page. What usually works best is that the therapist serves as the case manager and they're the ones telling everyone what the page is. That can sometimes be hard because what you're asking is for a therapist to tell an MD, this is what page we're on. We're asking them to call the school counselor or the school nurse and saying, this is what page we're on. And it can feel sometimes like we're swerving outside of our lanes. But it's more important than ever to make sure we're on the same page, and having someone take the lead with that, particularly the therapist case manager, ensures that that happens. So who can be on this care team? Basically anyone you can get. And it doesn't matter whether you have commercial insurance or you're county funded, it is hard to put together a care team. So you take who you can get. The care teams that we've successfully built include school nurses or school health aides, pediatricians, a wide definition of family. So we've had parents, but we've also had them bring in an aunt or a grandparent. We've had neighbors. We had a school theater teacher. We've had school music teachers. So somebody from the school, having a dietitian, and then you're going to unite everyone around a singular goal. And what that goal is weight gain. I'm not sure if in the others in the series you heard a little bit about the Minnesota male starvation study, but I think it's something something that it's great to hear about often and to become almost fluent in talking about it with your clients. If you Google it later too, there's some wonderful videos of different people talking about it, including someone who'd recovered from an eating disorder, really talking about what that study meant to them. So this study happened in the early 40s. There were a group of Mennonites in Minnesota who were conscientious objectors to the war and didn't want to enroll in the draft. So the US government said, okay, you don't need to enroll, but we'd like you to instead participate in this study. Clearly before IRBs got strict, this study was pretty intense. They all moved to the University of Minnesota and into the dorms that were below the football field. These were all healthy men between the ages of 18 and 35, no physical or mental illness. And for the first 12 weeks, they were closely monitored for both their activity level and what they consumed, and they were allowed to just do what they normally did. They took many tests. They took blood tests, they measured their weight, they did saliva tests, everything they could think of. And after 12 weeks, they started systematically starving these men. What the government was seeking to answer is, what is the best way to refeed people who have been starved? So they knew that during wartime, famine can occur. Maybe they knew that the Holocaust was going on and that there were going to be large amounts of people who had been starved. So how do we best refeed people? Do we start slowly increasing their calories? Do we give them all their food at once? So they started starving these men. And what they found is that as their weight went down, and I should note that most of these men were eating more than most of the patients that I see, even in the starvation state. But as they started losing weight, their anxiety increased, their depression increased, and also symptoms that we traditionally call eating disorder symptoms. The researchers even wrote in the journal, they said, they're turning into a bunch of anorexic little girls. So they were breaking their food into small pieces. They were making odd concoctions with their food. Mealtime, which used to be about 15 minutes to eat a meal, was now taking hours for them to finish a meal. They started doing body checking and pinching their body to see where they gained weight. Some self-harm started. One person even cut off one of their fingers. Increased suicidal ideation occurred, and others, lots of lethargy and other symptoms that I'm blanking on right now. But in general, what happened is we started seeing eating disorder symptoms, and it made us realize that a lot of the things we associate as eating disorder symptoms are actually symptoms of starvation. So the most important thing we can do is to get people to gain weight. What often happens in outpatient treatment is that we spend not just weeks, but months and years doing cognitive behavioral therapy to convince people to love their body, or convince people that they should want to go to soccer more than they should want to starve themselves, and trying to increase the motivation. But one of the things we learned from the Minnesota male starvation study, and kind of every patient since then, is that it's not going to happen. This motivation, this intrinsic motivation, is not going to kick in where people just want to eat. One of the things we learned from the study is that even long after people were fully weight restored, their eating disorder symptoms remained for a while. And again, these were people with zero body image concerns. So it's very important to orient the entire treatment team, the patient, and the family to the singular goal of weight gain. I don't want to talk about anything else. We're going to focus on weight gain. So all members of the treatment team should know the ideal body weight and make sure that we are setting it high. So for example, if someone had always weighed 120 pounds and they lost weight to 110 pounds, it's very common for us to hear things like, well, there's other people their age that weigh 110 pounds. And one of the parents might say, oh, I was slender when I was their age as well. No, we're going to return to 120 pounds and maybe even return to set the goal weight at 125 pounds because they're an adolescent. They're continuing to grow. They should be continuing to gain weight. And what we know is that the symptoms will not remit until they have full weight restoration and have been at full weight restoration. Gain the weight quickly. I put here 1 to 2 pounds per week. I know a lot of people who say 2 to 3 pounds per week. That is a safe rate to gain at, and you don't want to be doing this forever. If you have 10 pounds to gain, it could take 10 weeks if you do 1 pound a week, but there's a lot of people doing a quarter pound a week or a half pound a week. That will take forever. We also know the longer that someone is in a starvation state, the longer that someone is underweight, the more likely they are to have a chronic condition with frequent relapses. You gain 4 pounds in 4 weeks, you have a very high likelihood of making a full recovery. And so let's gain the weight and let's gain it quickly. So make sure everyone knows the ideal body weight. Another reason to set it higher is we give the families the metaphor of having a picnic on the edge of a cliff. So I'm talking to y'all from San Diego, so we have Torrey Pines, we have some beautiful cliffs overlooking the ocean. And if I went there with my family, especially with my 6-year-old boy who just runs, we would not set up our picnic right on the edge of the cliff. We would still enjoy the view, but we would go away from the edge of the cliff. The same thing is true when you're setting a goal weight. If we think that if they're below 120, the depression, anxiety, and eating disorder thoughts are going to return, we don't want a goal weight at 120 because they're just one flu season, finals week breakup away from going right back down to 115 and 110. We know that for most of the population, losing weight is really hard, but for this 1% that we're taking care of, they're really good at losing weight. So let's set the weight goal at 125, so if they get the flu, they're still in a safe spot. And then just keep weight the priority. So every week they're going to be bringing in new things, hearing about tantrums that occurred, self-harm that's happening, and there's this tendency to want to go solve the problem of the day. And I start every session with, what do you want to put on the agenda? I hear about all these crises that are going on in their lives, and I'm like, I'm so excited to talk about those things, but let's find out what your weight is. You gained 1 to 2 pounds this week. Great. What did you do that gave you that success? How can we make sure you have that success again this week? If you didn't, okay, how are we going to have that success? And that's the only thing we talk about until we're consistently having the weight gain every week. So in order to get these, you're gonna be like, this is great, but how am I going to get the family to put 1 to 3 pounds on them per week? So mobilize the families. Take a broad definition of family, since people have to eat probably 5 to 6 times per day in order to get the 1 to 3 pounds per week of weight gain. You're going to need a lot of different people helping to supervise them. We're encouraging the families to supervise and also provide direction for the meal. So what we hear from people with eating disorders is, well, all of them will say they don't want their family involved. And this is in fact a study that I did. We looked at 50 adolescents, 0 of them wanted their family to be involved in treatment. At the end of treatment, all but 1 of them was incredibly glad that their family was involved, wished their family was involved earlier, said they would not have gotten better as quickly without their family involved, and that they now feel closer than ever to their family because they're involved. And again, I'm using a broad definition of family. We've had everything from a kid come in with their mom and their mom's boyfriend and their dad's new wife and a grandma. And then we've had a family which just looks like a child and one parent, or a child and foster parent. So whatever family looks like, but know that we're never going to be able to convince the adolescents to want to have their family involved. Instead, we're just working directly with the adults in the room, the people without eating disorders in the room, and be like, you're the one I need to convince. I need to convince you adults that you can feed your child, and we're going to do it whether your child wants to or not. And one way we do this is by identifying salient rewards and consequences. Doing a quick time check here. One of my favorite examples is there was a child who was hypermetabolic, needed about 3,500 calories per day in order to gain 1 to 2 pounds per week. And so what the family was doing 3 solid meals, but then they were making the shake that had about 1,000 calories in the shake. And that way she would get all the caloric calories that she needed. And the dad came in and he's like, I'm so sick of the shake. You know, I make it in the morning. We fight about it all day long. I find it like languishing on the coffee table at the end of the day. And, you know, she's drank like 25% of it. What are we going to do? What are we going to do? So one of the things we talk about is that we haven't found a gene that's passed from parent to offspring for eating disorders. Instead, what we found is a set of temperament traits that are passed from parent to offspring, and the ways in which these temperament traits are wired in the brain. And we've learned that the reward circuitry in the brain is less active in the brains of people with eating disorders, but the consequent circuitry constantly firing. Quick example using a bunny. So our brains are mammalian brains, not that different than other mammals like a bunny. And if the bunny was sitting in its cozy, warm bunny hole, at some point, the reward circuitry in the brain needs to start firing to tell that bunny to leave its warm, safe hole and go look for carrots. Now, this reward circuitry is firing, go look for carrots, go look for carrots. And if all of a sudden, while it's out in the field, it sees a fox, that reward circuitry needs to immediately become inhibited. And the consequent circuitry, the fear for your life, needs to kick in and send the bunny back to the bunny hole. What we see in eating disorders, though, is that the consequent circuitry is so great that that bunny dies in the bunny hole and never goes and looks for carrots again because it's so afraid of the fox that might be in the field while it looks for carrots. This is why some of our high-income families will say things like, I offered to buy her a car, I offered to buy him or send him on a ski vacation if he would just gain 10, 15 pounds, and he won't do it. It makes no sense to me. Well, the rewards aren't salient, but consequences. So we talked with this dad and reminded them about consequences are salient. What would be a salient consequence for your child? Came back the next week, high-fiving everyone, so excited. And he's like, I figured it out. So he made the shake in the morning and said to his daughter, okay, I'm not going to give you the shake now. I put it in the car. And so when we get in the car, I'm going to drive you to school. We're going to leave at 7:50. It takes 10 minutes to get to school. And we'll get to school like 10 minutes before school starts, because it doesn't start till 8:10 or like 8:07. I feel like schools nowadays start at really odd times, like 8:07 and then end at 2:13. Anyways, so he did this, and when they got in the car, he's like, okay, and you can go into your first period class as soon as you finish your shake. And don't worry, like I sent an email to your school letting them know you'd sometimes be late to first period. And don't worry, I've made sure that I didn't have anything I had to get to first thing when I arrived at work. And sure enough, she finished that shake immediately and got into school on time, because the consequence of being late to her first period, having everyone turn around and look at her as she walked in, that consequence felt so great that she couldn't handle it. That was salient to her. And so she finished that shake every single morning in 8 minutes on the drive to school, and gained 1 to 2 pounds per week every week, and has been in full recovery for many years. And lastly, structuring the environment for recovery. That can look lots of different ways. For a family that has no carbohydrates or gluten, bringing that back into the environment. For a family that's under-resourced and needs to get some meal stamps or access to a food bank, using that and telling them what food to go get when they're at the food bank. What are some high-density foods to have available? That can mean calling in other adults to do supervision at different times of the day. That can mean talking to the school nurse. So you as the therapist and the case manager, we talk to school nurses all the time, or school health coordinators, and say, this child is going to be joining you in the nurse's office for lunch. This is what their lunch will always be. Please watch them eat it so we know that they're consuming their lunch. So those are some ideas. There are a lot of great resources out there for families that are free, and that we try to get into the hands of as many people as possible. So first is Feast. It is an international organization. Their website is just full of information. It's full of parents helping other parents to refeed their children who are struggling with an eating disorder. I know I've been talking a lot about refeeding. It also includes how to supervise your child who is binging and purging, how to supervise your child who is doing self-harm. So there's the website for Feast, and it'll be in the slides that you can access. They also are in multiple languages because they are international as well. Parents to Parents has some great videos that on YouTube for free that can watch, other parents talking about how they did that. Here's another YouTube video of how parents can help at meal times with examples of children negotiating and how the parents can negotiate back. and Eva Musby also has some great videos as well. And then my favorite book that I recommend to every treatment provider, I send it to every MD, dietitian, peer mentor, family mentor, anyone who's going to be treating eating disorders, and then also anyone who has it, is Lauren Mulheim's book, When Your Teen Has an Eating Disorder. And it has very, very practical strategies to help a teen recover from anorexia, bulimia, and binge eating. We say to parents all the time, listen, I cannot become an expert in your child. This is your child, but you, parent, can become an expert in an eating disorder, in eating disorders, and this is all the resources I'm going to give you to help you get there. Quickly, I want to mention though that I bet none of you, so now there's 68 people on the call, I'm assuming 0 of you have ever treated a patient who just has an eating disorder and has nothing else going on. So eating disorders have more comorbidities than any other mental health illness. So substance use, once you cross age 18, if you have an eating disorder, 50% of people with eating disorders also have substance use disorder. We also see a lot of self-harm, binging and purging, suicidality, and school refusal. One thing to mention, this ends up feeling often like whack-a-mole. So someone's eating disorder might get better, but their substance use will get worse, or their substance use will get better, but their eating disorder will get worse. Same thing with self-harm. So recognizing that the same thing underlies these are tools that are being used to cope with the same thing, right? So we talk with people who have just really big emotions. They struggle with emotion regulation, and when they are feeling a 10 out of 10 angry, if they purge, they feel instantly better. They stop purging, they might start self-harming a bit more, because cutting also makes them feel instantly better. So validating, like, it makes sense that you want to stop feeling 10 out of 10 upset. I don't like feeling 10 out of 10 upset either. I know you don't want to purge. I know you're kind of ambivalent about whether or not to self-harm. We need to find something else as well. Okay, but so what you're doing is seeing patients that have that whole long list of things going on, and it makes them seem like, wait, should they even be here an outpatient? They need to go someplace else. I'm sure most of us have thought that with a patient before, like, whoa, like they're self-harming and they're school truant and they're running away and they're restricting, and when they do eat, they purge, and I think that they are using substances as well. Like, this is too complex of a case for outpatient. I think in a perfect world, there would be a place to send people, but know that even if you have commercial insurance, there isn't any evidence-based place to go. We don't have a higher level of care that actually does this in an effective way. And instead, what we see happening is, if you are able to send them to a higher level of care, they end up coming back to outpatient, and you're just right where you started. So we're either going to figure it out at outpatient now, or we're going to figure it out later, but rarely is it a higher level of care effective right now. I think another thing that's hard is assessing, is something complex or something acute. So I work a lot with emergency rooms, emergency departments, and they see a lot of these kiddos. And what happens is they see them, they talk to them, and they send them home the same day, because they also don't have any place to send them. And oftentimes it is not acute. One of the difficulties is that sending people to the emergency department can often reinforce the eating disorder. So things that I've seen happen, first of all, let's say you are eating dinner with your family. You do not want to eat the dinner that the parents have offered you. So you throw a tantrum, you threaten to kill yourself, like, it's not worth living. This obviously makes the parents scared. They call 911. They end up having PERT come, and it takes them to the emergency department for an evaluation. The eating disorder has just won in that scenario, because while the police are coming and you're going for an evaluation, you go to the emergency department, what you're not doing is eating. So the eating disorder now knows that if I want to miss a meal, or I want to miss a snack, a tantrum, a trip to the emergency department, a psychiatric evaluation will all get me out of eating. There's also the emotional reinforcement. People who work in healthcare, we're all really nice people. Look at me just patting myself on the back, but like, we're all really nice people. And so if you don't work in eating disorders, it's really easy we might be working with a patient for a while, and we don't want to reinforce their use of talking about suicidality as a skill. We'd like them to get other skills instead. And then they go to an emergency department talking about suicidality, and they might get a really well-meaning person saying, like, but oh, but you're so beautiful and you're so wonderful and like you shouldn't die, and giving them a lot of emotional attention for behaviors that we're actually trying to extinguish and we don't want to be attending to. Which goes to the third point of people leaning on their suicidal ideation instead of leaning on their skills. So most people with eating disorders have passive suicidal ideation. This is scary because we do see higher rates of suicide in people with eating disorders than in other areas. However, most of the time it is just ideation. There is not a plan, there is not a means to utilize the plan. And every time the suicide ideation works, it gets them what they need, then they're going to continue going to that instead of using skills. We take a really DBT approach at Equip Health, where I work now, and also at UC San Diego, of how we assess different suicidal behaviors that come up and how we direct them to skill use. Sending to the emergency department can also reinforce the message of parents, you can't do this, right? It's again taking the kid away from the family and saying, you can't do this. And the more parents think they can't do this, the easier it is for them to not serve their child that meal and fight with them about why they have to eat all these calories. Another problem that happens often in emergency departments is they're rarely admitted, which leads to this I'm not sick enough thought that goes on in their head that again feeds and reinforces the eating disorder. And then lastly, we're delaying the inevitable. In the end, they are all going to end up in outpatient treatment because the higher level of care, whether you're using commercial insurance or not, are just not satisfactory right now. They aren't yielding improvements. They are reinforcing the patient role. So they're going to come back later to outpatient with the same problems that they had when you send them out. And that's the sad, unfortunate truth. And the longer that they've been ill, the longer they've been in the patient role, the harder the treatment gets. So doing the hard case now versus the hard case 6 months from now when they come back. Okay, so when do we send them to an emergency department? I just spent a lot of time saying, just don't send them, don't send them. If there is acute medical instability, so if the body weight is under 75% of what their body weight should be, they should weigh 100 pounds, if they're 5 feet and they should weigh 100 pounds and they weigh 70 pounds, send them to the emergency department and they should qualify for inpatient medical stabilization. That being said, that's true for the 18 and under crowd, but I'm sure many of you are treating people 19 and up. So their body weight has been maybe under 75% for a long time. It's not acute medical instability. Our bodies are crazy, weird things, right? Our bodies want to survive. They don't care if we're happy. They just care that we pass our genes on. We've seen people have very, very low body weights who are somehow pregnant and carrying a healthy baby. So it is not necessary to send someone to an emergency department when they're underweight if they've been chronically underweight. Abnormal labs, if the labs come back abnormal, if we think that they're water loading, or if their heart rate is under 45 beats per minute when they're resting. Those are acute medical reasons to send someone to the emergency department. For acute suicidality, it's if the family is unable to supervise them. So it's not uncommon for teens to express suicidal thoughts when going through eating disorder treatment, and that's when I kind of don't respond to the child and I say to the parents, your child is feeling like they might harm themselves. Can they sleep in a sleeping bag on the floor of your room tonight? Are you willing to take the door off of their room in order to supervise them 24/7? Have you removed all the guns from your home? Are you able to lock up all of the knives and sharps? Are you able to lock up all the medications in your home or bring them to a neighbor's house, something like that? So for kids who are having this kind of chronic suicidal thoughts, it is more effective in the long term to teach the parents how to manage that and supervise it. Also, than to send them to a 72-hour hold, but also the parents learning how to manage it, which is a skill that no parent was born with, right? They don't have a book for that, so it is something that we have to teach them and build up their distress tolerance. But then managing it can also help to extinguish that behavior. If a child is trying to earn their door back, their door to their bedroom so that they can have privacy, be like, well, you tell me you're thinking of killing yourself, so you're getting zero privacy until you're not thinking that way anymore. Those types of things can help to extinguish the going to the self-harm or the suicidal thoughts. Okay, communicating need for a higher level of care. I'm going to wrap this up in 2 minutes and pass this on. So if someone needs a higher level of care and you're trying to effectively communicate to the payer the reasons why, the case manager the reasons why, obviously have the vitals, the labs, the EKG, and medical complexities. It's very hard to get a higher level of care without the medical complexities. Focus on measurable symptoms and a list of interventions tried. So weight is a great measurable symptom, frequency of purging, frequency of self-harm. So they were self-harming 12 times per week. The intervention that we've been doing is the whole family comes in and learns skills. The parents have been asked to sweep the room for sharps every night, and the child isn't allowed a lock on their door. And now they've gone from self-harming 12 times a week, and now they're down to 6 times a week. However, we've now been at 6 times a week for X number of weeks, despite these new interventions that we've tried. So it really helps if you talk to them in terms of what are the specific symptoms, what are the interventions that you've tried. And then lastly, what are the resources that are available after a higher level of care? People are understandably hesitant to send to a higher level of care if there is nothing available for them afterwards. And I said this in the beginning, and I hope that after this 4th seminar, you're starting to feel this way. You are now more of an eating disorder expert than most anybody else that's practicing in mental health right now, because you've done these 4 trainings and you're going to continue to learn about eating disorders. There's not like a unicorn land of mythical perfect eating disorder experts anywhere. So ways to keep becoming eating disorder experts. So UC San Diego has a free web seminar. It's every other Tuesday at noon Pacific time. You can find the link on their website and sign up for an email address. The Academy for Eating Disorders has free webinars as well. And then there's many other people, but I include one here. Tara DeLiberto has a YouTube channel full of videos talking about how you can talk about this stuff with families. She also wrote the book. This is a picture right here called Treating Eating Disorders in Adolescence. It has very, very specific examples, worksheets that you can give your clients. And then the other books that I like is obviously the one I mentioned, When Your Teen Has an Eating Disorder by Mulheim, and then Locke and LaGrange have come up with 2 treatment manuals for anorexia and bulimia. Okay, so I'm going to turn this over to Margaret. I'm going to say it's Kislyak. I didn't practice your last name either. Hopefully I got that right. So let me stop showing my screen and change presenter to Margaret.
Thank you, Dr. Parks. I have passed presenter control over to Margaret for you, so there's nothing you need to do now. And I think Margaret is sharing her screen now. Perfect.
Thank you very much. And everybody said it right, no matter how they said it. In my family, that's how we go. It's a pleasure for me to be able to participate in these webinars. I'm going to do a brief overview and then turn it over to the folks that have been doing the real heavy lifting on our work with eating disorders. A Partnership Health Plan administers Medi-Cal in 14 Northern California counties, pictured here. The salient point about this is that means that we work with 14 different managed care mental health plans and a very diverse population and service structure. Next slide. So basically, this is what we've experienced is an increasing number of cases, and this is sort of a summary of the experience that we've had to date. When we hear about these cases, it's usually when the client's reached an acute level of need and there's been delays in diagnosis and treatment. We've been struggling as our providers with the diffuse system. Medi-Cal on its own is pretty diffuse to start with the mental health benefits split up and the services dispersed differently among our counties. And this is an even more diffuse system when we're talking about eating disorders. We've also experienced a very limited set of resources and expertise available to us. And we've increasingly seen the need to address this systematically within our system and with our county partners. So this is what we're doing. We are working to help our providers develop the expertise. This webinar is an example. We're working to develop experts for consults and encouraging other training and evidence-based practices. We're working with our county behavioral health, mental health plans and behavioral health directors to establish the best way to collaborate and to try to rationalize the parts of our system that are not particularly rational to start with. We're working with Beacon Health Options, our mental health provider, to help build the expertise and resources within our community. I really appreciated Dr. Park's comments about residential care, because there is none of that available within our 14 counties. At least for Medi-Cal clients, and so we really need to we want to work to do what we can to build resources close to home. And finally, we're looking at our data and trying to improve our experiences, our ability, excuse me, to focus on early detection and how we can best treat cases as early as possible. I'm turning it over to Laurel McCarthy, who is our care coordinator, who's done a fabulous job of working with our counties and trying to wend her way through this difficult system that we face.
Hi, yes, I'm a social worker in the care coordination department, and I've been asked to talk about some of the care coordination challenges I've experienced, and also to touch on the role of county mental health services in eating disorder care. One of the first challenges is the collection of all the information needed to determine the appropriate level of care. As Dr. Parks mentioned, we do need to have medical information provided as well as mental health information provided in order to find out where a member is at and whether or not they need a particular level of care. So there needs to be someone available to collect the information and also to evaluate both the mental health and the medical side of information. And in some situations, it just isn't always clear who that is or who it should be. Interdisciplinary approaches are not as standard as we'd like them to be. I think on an intellectual level, most of us recognize that an interdisciplinary approach is really valuable, but in real life, it's pretty challenging to make it happen unless it's already standardized or in place in your agency. So we often see our patients in our own silos, and we're not always used to working with outside programs. We don't know who to call, how to engage them, whether they'll be receptive, and sometimes that means we don't talk to one another often enough. Mental health providers, pretty rarely in my experience, are already talking to PCPs, to the primary care physicians, about a member's vitals or weight, even though the standard of care would ideally be that a member is going to their PCP once a week and that the mental health providers and the PCPs are talking to one another. And a registered dietitian often isn't engaged in the care at all, and if they are, there's not a lot of communication. I will say that when I started the process of contacting providers, a lot of them are feeling stuck and they're really eager to work together with the team. So I've actually had very positive experiences reaching out to people. But I'm just finding that many people haven't been able to put care teams together unless they're all together in one agency already. We've already talked a lot about the difficulty in locating providers experienced in treating the population, and particularly with Medi-Cal. So the only thing I'll mention about that is that it is a care coordination challenge, and also that especially when we are in needing of a higher level of care, we are often having to pursue out-of-county placements and single case agreements for each individual member, and that really can slow things down. Counties are having to do that one at a time instead of having easy systems in place. And that leads me to my next big care coordination challenge, which is that systems can move pretty slowly. That doesn't come as a surprise to anybody, but the reality is that many of our counties are still ironing out their processes for dealing with eating disorders. Margaret touched on how partnership is working with our counties to try to get standard systems in place, but they just aren't in a lot of places yet. This means that we need to advocate early, and we need to advocate often, and we need to follow up with referrals over and over again. It can be very uncomfortable, to be honest, to do that. But it is effective in moving systems along. It's usually not the individuals who are stymieing us, but just kind of the whole system moving slow as molasses sometimes. And that also means that we can't breathe a sigh of relief when a very ill member has gotten into residential care and just stop there. We have to start planning for discharge right away. Even with the whole team working together in systems where the teams really are working well together, we often haven't been able to get the discharge plan fully in place by the time the member's ready for discharge. So the earlier you get started, the better. And lastly, it is important to acknowledge that ambivalence about the need for treatment can slow down access to care, particularly with adolescents whose family members are not willing to push them or make them go into treatment. As Dr. Parks mentioned, it's rare that teens want their families involved, and it's also sometimes true that parents aren't willing. If the member says, I don't want treatment, or I'm not going there, families may not want to disturb their relationship that may already be poor with their child and push them to do something they don't want to do. A lot of the cases that have come to our attention are cases that are really at a very emergent level, partially because treatment hasn't been sought earlier or hasn't been followed through on. That does not mean to blame the patients and families only, but it is absolutely a challenge. The role of county mental health can be confusing to a lot of people, particularly because the health plan also has a role. And so I just wanted to touch a little bit on what the different roles are. And first off, I should say that there's always a role for the health plan because of the physical health care needs of the patients. So we work, partnership health plan and any Medi-Cal health plan works together with counties and community providers to provide the treatment. For mild to moderate cases, the mental health treatment side of treatment is provided by the health plan. For partnership members, this is the Beacon provider network of therapists that Margaret mentioned earlier. They typically provide individual and family treatment. For more serious cases under Title IX, they fall under specialty mental health services. And that means that the county, and usually the county mental health department, is responsible for the care decisions in these serious cases. It's also possible that patients may step up to county services and then step back down to community providers through the course of their treatment. So that's just something that's important to be aware of. For partnership members, we just suggest that everybody who needs eating disorders treatment be referred to Beacon Health Options. Beacon has case managers that can help determine the level of care that's needed and help connect the member to the appropriate services and navigate the step up, the step down, the different systems that are happening in each county. So it's a real benefit that Beacon can help with that, and we just suggest sending people directly to Beacon. They can also provide some assistance to current mental health providers if they're needing assistance in providing eating disorders care to a patient, or they can refer to another outpatient provider if that's needed in a particular case. And lastly, the partnership health plan and any Medi-Cal plan has a care coordination department, and we can definitely assist with care coordination, advocating within counties if needed, and just making sure that all the care is in place. So that's the end of my spiel, and I will be passing it on to Dr. Jeff DeVito.
Okay, hi everyone. My name is Jeff DeVito, and I'm a psychiatrist with addiction psychiatry specialty training. And I'm going to talk about one very specific thing, but I'm going to kind of try to frame this as best I can. One thing that, in order to frame this, that I like to talk about is that a couple of years ago when I came on board with Partnership Health Plan, where I'm currently, by the way, the behavioral health clinical director, I mentioned to Margaret and others, I said, listen, I am completely comfortable with all manner of sort of psychiatric illness, from schizophrenia to bipolar, and certainly addictions is a certain specialty and interest of mine. But I need you to understand that there are two areas that I don't feel like I've got a lot of expertise in, and that's eating disorders and children. So, well, time went on, and I've become more acquainted with these as the cases have come up. Now, I'm framing it this way because I also think that there's been some advantage to that, which is that I'm making no allusions to the idea that I'm any kind of clinical expert in eating disorders. So it's kind of put me in some ways a position of being able to observe how things are playing out without any preconceived sort of clinical or other background, and I can kind of take a look at the system as a whole and look for areas that I see as sort of being universal needs. So the thing that I've noticed in a lot of these cases, as was highlighted by Laurel and Margaret and others, is that there are a lot of transitions of care. And when you start talking about mild to moderate and then serious mental illness, and in each of those distinctions, there are different levels of care, different places where people would access treatment. It's very easy to lose sight of clinical ownership of the client. And that's one area, and this isn't unique to eating disorders, by the way, but this, I think, is kind of a universal truth with dealing with a lot of very complex clients that have a lot of different co-occurring disorders, is that it is really important to be able to identify through those transitions who the clinical lead is. So where does the buck stop in terms of clinical decision making? Because there's going to be potentially a lot of case managers and a lot of different care coordinators that are going to be working around the clock to kind of help develop options and develop referral networks and getting people, teed up to be able to move into different types of care. But ultimately, there does need to be a certain amount of recognition of who the clinical lead and who the sort of clinical ownership or where the clinical ownership rests. So that's been kind of the theme that I've, for better or for worse, developed in time as we've started to talk about these complex cases, is right out of the gate saying like, okay, who's clinical lead? Is it the pediatrician? Has someone talked to the pediatrician about being the clinical lead and understanding that they're kind of in charge of this? Not in charge of it in terms of, making everything happen, but being in charge of sort of, when there's a discrepancy that might come up or where there's some confusion that might come up about what's going on, who's the person that the team is turning to at that point to say, okay, we need a medical decision maker at this point to help us navigate to the next step. So again, I said that my little section here was basically one point that I probably could have said in one sentence, but I've managed to extend it out into many more sentences than one.
All right, great. Well, thank you very much. That actually does bring us to the end of our time together today. So I recognize that we did not have an opportunity to open it up for Q&A. And so what I would like to do for you all is I'm going to go ahead and leave our webinar session open for a while, and you can chat in any questions that you have. Any questions that were chatted in, we will have either one of our presenters today or CPCA staff follow up with you afterwards, but we will make sure to still address any questions that are still remaining. I want to go ahead and thank our panelists for their time today, for this valuable presentation to our members. I know we all appreciate it. And then I want to thank our audience today for their participation. So thank you for hanging in there with us with our small delay in the start. Again, apologies for our technical difficulties, but I think you all hung with us for a really great session. So thank you again, everyone, and have a wonderful afternoon.